Good afternoon, everybody. Respected dignitaries, faculties, dear friends. My sincere thanks for making us a part of this novel initiatives. I still remember it was in the meeting in the Chennai way back in 2011. Under the banner of Indo-British Health Initiative, Professor Elvin Elias was my co-chair. And that day the topic was also on NAFEL. At the end of the meeting, he commented, there are too much of data without any directions. Next. Today, we realize it is not a single entity. It is a matter of amalgamation of different diseases. So obviously, it can't be a unidirectional. This cartoon is self-explanatory. The term fatty liver came to existence in the year 1845. Since alcohol also can give rise to similar pathology, it became imperative to differentiate. Hence, the word non-alcoholic fatty liver was created. It took almost a century to realize that NAFEL progressed to NAS. Later on, the idea was conceived that it is a systemic disease. Other offshoots, the idea is that now it is NAS, then say it is a case of metabolic liver disease. So there's a lot of controversy. I will not go into those naming problems. And the core issue is, what is the cause? Why it is happening? There are multiple players, including genes, diet, microbiome. Again, if you go into pathogenesis, it is mind-boggling. So those details are for the experts, those subsequently will take up these issues. Let's see how it progresses. It is a global disease. It takes about 8 years in which 25% of it progresses to next stage of the disease. And if you see a relatively faster rate, and most important is all the way it remains asymptomatic. Notable fact is the commonest cause of death is related to cardiovascular disease. And as I've already mentioned, it is a global problem. This is the data from different parts of the country. And if you look into this, the news is not very encouraging at all. The worst is it also affects our children. So the magnitude is really enormous. What is the impact of this? There is a huge burden of disease. There are coexisting morbidities and also associated cardiovascular risk and mortalities. So at the end, you have sufferings of the health, not only health, economy of the country also suffers. So what do? When you do not have a specific curative measures, prevention is always better. Out of this, the last two, like early screening and follow-up, and tackling other metabolic counterparts is very important as far as early disease diagnosis is concerned. Next, please. The screening is not so easy. And there's a lot of difference between a real life and ideal world. The tools available for screenings are one, it is cost. The cost factor is important. And moreover, this availability is also important. So we all of us agree, something has to be done. We need a change. But what needs to change? There will need to change the perceptions. There is a need to change the protocols. There is a need to change the practices. And there is a need to change the policies. And more importantly, the awareness among the masses has to go off. So this slide summarizes that there is a need for a national program. There are 3 different diseases, mostly hypertension, diabetes, dyslipidemia, many more things are associated with disease. Disease burdens are pretty high. And moreover, it is a silent course with grave consequences. Early screening and intervention only can halt this progressive disease. This required a better resource utilization at a national level. And I'm happy to say that India is the first country to bring this into the control program. And this is already corroborated by the message from our honorable health ministers. It's already in the national program and operational guidelines are already in place, which is quite evident from this. And I'm very hopeful about this. This slide, this is a point of a hepatologist point of view. There are 4 pillars where an hepatologist can depends the control disease. One is primary care level, where the awareness and access is very important, and this has to be integrated with the healthcare system at the primary level. When you come to secondary and tertiary level, we need to clinical resources has to be available, and there has to be collaborative networks as the management is concerned, because multi-system disease. So at the end, to conclude, I quote a quote from an editorial from Hepatology Journals 2018. So probably the primary care health access and awareness to integrated with the healthcare systems, available with the clinical facilities, all needed collaborations. And for the next generation hepatology is probably the BG remain busy with the same problem, because I feel the load is enormous. With this, I take, thank you very much for your patient hearings.